especially with regards to cancer. And with a good acumen and a good knowledge, you can actually do a lot of wonders to this particular problem, which is a menace worldwide, I would say. Worldwide, yeah. So when we speak about pain and the definition of pain, as per the WHO definition, pain is a very unpleasant sensory and emotional experience. Okay? And usually it is associated with actual or potential tissue damage. So to have pain, there must be something happening at that particular place. And that place actually may be having an injury, and the injury leads to a tissue damage, and that leads to the symptom of pain. Or sometimes it is described in terms of such damage. So when we speak about pain, it is a very, very vast symptom, and it has varied presentation. So we speak in terms of whether it is a nociceptive pain arising from the tissues of the skin and glands and organs, or it may be a neuropathic pain arising out of the nerves and something happening at the neuronal level. It may be an acute pain of a sudden onset, or it may be a chronic pain happening over a period of time. It may be a cancerous pain, it may be a non-cancerous pain. So many definitions of pain, so many subcategories of pain as you learn. So we all pretty well know pain is what the patient says, isn't it? If the patient has pain, obviously he will bring it to the notice of the caretaker or the doctor or the relevant healthcare professional. And pain is extremely subjective. Okay, what may be pain for somebody may not be pain for others. And it all depends on the way you look at it. And the most important thing is self-report of pain is the single most reliable indicator of pain. Always, if the person who suffers pain will make it a point to bring it to the notice of the doctor, because they don't want to take it for a very long time. The pain is something, it is a very agonizing feeling, and you don't want to suffer for a long time. You take the example of the colicky pain of the babies and the small toddlers. They cry and they seek the attention of the mother. Okay, once the mother gets to know the child is crying, either the baby gets a feed, because it may be because of what we call hunger pang, or they may just give some small medication to counter the gaseous distension of the stomach, so that once that is relieved, the child quietly sleeps off or starts playing around. Okay, so this is a simple example of how pain can be tackled. And recently, pain has been included as the fifth vital sign, because it just goes to show the importance given to the pain, and you need to look at it in a very serious manner. Okay. So as I was telling you, there are many types of pain, and it is classified based on the duration of pain. It is classified based on the location of pain, on the intensity of pain, and the etiology from where it arises. Okay, these are the types of pain. So based on the duration of the pain, it can be classified as an acute or a chronic pain. Some slides are repetitive, just to enlighten you. Okay, so an acute or a chronic pain, and under chronic pain you have some subcategories like chronic non-cancer pain, chronic cancer pain, chronic episodic pain. Chronic episodic pain is something, to give a small example, sometimes what happens, the pain of the appendix, it comes as an episodic form. The patient will have severe agonizing pain abdomen, like a spasmodic pain, and gradually it decreases. And again it recurs. Similarly, the pain of the pancreatitis, this also comes like an episodic pain. And sometimes the pain of the advanced cancer of the stomach, once you eat, it follows it is what we call as postprandial pain. It lasts for some time and again it goes out. Again, the colicky pain or the pain arising out of the renal caliculi, also they present as episodic pains. Okay? So again, according to the duration, as I told you, it is classified into an acute and a chronic pain. Is the slide clear?
Yes, sir.
Hello?
Yes,
okay,
sir,
okay.
It is clear, sir.
So, acute pain and chronic pain. Acute pain is something of a very recent onset, commonly associated with some injury damage. Okay, so you can pinpoint and say the pain is because of this, and always it is mostly like a sharp shooting pain or a colicky pain or a cramp-like pain or something called like pressure-like pain. So there are so many types of characters of the pain. So it may be starting within seconds and it may last up to a few months. This is acute pain. Usually it is a very localized pain, but sometimes it has a referral component. For example, the pain coming from the gallbladder stone. The pain usually starts at the right hypochondrium. We call it as right hypochondrium at the level of the ninth intercostal the costal area, and the pain of this gets referred to the right shoulder. So this is what we call as a referred pain. Okay, and usually it is associated with severe sympathetic hyperactivity. The patient will have severe sympathetic overdrive. Whereas a chronic pain is something that comes and lasts for more than 3 months. So an acute pain lasting for more than 3 months becomes chronic. So it may be a constant or an intermittent pain, and it presents beyond the the healing time. It lasts for more than the healing time, and you cannot pinpoint and say where and what is causing this pain. Okay, it may be a dull ache, dull constant pain, dull pressure-like pain, and also usually what happens is the autonomic disturbance will be normalized. They don't have that sympathetic overdrive, but the most important thing is the other features of the chronic pain will start emerging. That I'll explain. So the other pain what we normally see is the cancer-related pain, and it may be classified according to its location or the etiology. Okay, again it may be acute or chronic pain, and mostly it is arising out of a certain disease-specific area, and it may also arise when the disease spreads to as a metastatic disease to other parts. You should also remember that any cancer that spreads to the bone will have intense pain presentation. So based on the location, you can classify the pain. So headache, again, headache itself is a big chapter. We can discuss it out later. Headache can present with variety of pain characters, and it has so many features, and it presents like a with or without vomiting. It may present as with or without the blurring of eye. It may affect the pupils, pinpoint pupil, dilated pupil. So many types of variety of headache presentation. Again, if it is a cardiac pain, it is usually arising in the left side of the chest, and the patient may have intense pressure-like symptom. And when somebody experiences severe angina, they say that they felt as if an elephant is sitting on their chest. So that is the intensity of pain they go through. Okay, and again, this pain may get referred to the jaw, the left side of the neck. It may go to the left shoulder, or it may go right up to the left fingers. That is the cardiac. Respiratory pain is usually dependent on the breathing pattern. If it is a pleural pain, deep inspiration causes pain. If it is a pain arising out of the rib cages and other things, it causes shortness of breath because of the limitation of the what we call as the inspiration or the deep inspiration. And abdominal pain usually has a very varied presentation. Again, this itself is a major chapter to discuss. Just to give you a few hints, if it is a gastric pain, pain arising out of the severe gastritis, patient will have an epigastric pain, maybe a very localized pain. Sometimes they will have what we call as an acid reflux-like phenomenon, where they will get that experience of acid hitting their throat. That is the gastric pain. Pain arising out of the gallbladder, I told you, localized to the right hypochondriac area, referring to the shoulder. Pain from the appendix comes from the right lower part of the abdomen, and pain that is out of probably amoebic dysentery. They will have a very diffuse pain all over the abdomen, sometimes localized to the left lower part of the abdomen. So these are simple presentations of the abdominal pain. Of course, joint pains are very variable, extremely agonizing and very, very painful, and it makes the physical exertion extremely difficult. Lot of limitation in their physical activity. They mostly get confined to certain areas, and these are the patients who go for long-term self-analgesia, analgesic abused. Back pain again is a major issue. It may be, it has a varied presentation depending on the level of involvement of the bone and the vertebra. Vascular pains are very common. Vascular headaches are very common. Vascular spasm-induced abdominal cramps are very, very common. Again, those involving the nerve will have a very, very varied presentation. Mostly they are associated with tingling and numbness, and they may even have sometimes what you call as a limitation of the motor activity. And these are the patients who have a very progressive long-term complication because of the nerve entrapment or the nerve disease. And also I had earlier told about the referred pains that usually happen. So what are the factors that influence any patient with pain? So first and foremost is past experience. If somebody who has had pain from childhood and who present pain, you know what happens is they would have gone through this for a very long time and they get readjusted themselves. You know, their mindset gets adjusted to this pain because it becomes a chronicity for them, and you know they properly they can tolerate pain better than anybody else. They live with it. You know, they literally live with it. Okay, they are better prepared, and you know, and probably they don't express or you know, they don't go overboard to tell about the pain too much to the physician. Whereas a novice person, somebody who has never had an experience of pain, they present with severity is quite high, and you know they are more anxious and they want to get rid of the pain more rapidly. Okay. Again, a personality of the anxiety type, you know, those related to pain increase the pain perception, and those unrelated to pain may act as a distract and reduce the pain perception. You know, sometimes anxiety, somebody has anxiety over pain, they try to distract themselves from the, by you know, too much of focus on the pain, they try to get away from it. They start doing some other activities to overcome this anxiety over pain. Some people listen to music, some people watch various programs, some people try to do some physical activity to overcome this pain. So the anxiety works like two ways. Some people go overboard and they try to increase their pain, others try to counter it by trying to get away from this part. And obviously, when the pain becomes chronic, they lead to depression, and it's directly proportional to the duration of the pain. There are other factors, age. Again, some of these, you know, elderly patients and elderly people with osteoarthritis and other age-related issues, they tend to live with the problem. They live with the problem, and they are less expressive. They don't necessarily keep bringing it to the notice of the family members or even the doctors or whomsoever. And they probably realize that it is an age-related issue and they have to live with it. It also depends on the cultural background from where you hail from. Okay? If somebody, for example, somebody who hails from a village and somebody who is hailing from urban area. Somebody who hails from village, you know, they are sort of ruffians. They grow with a lot of pebbles and thorns in their life, and they tend to manage this particular pain part without any much publicity, I would say. Whereas those in the urban area, they are more sensitive, I feel, and they want to, you know, at any cost get rid of the problem, and they don't want to experience this again and again. So there's basically cultural background and probably even the religious background whatsoever you can say. And obviously in gender, the males tend to somehow hold back the problem, and they don't want to express too much. Probably that's what the mindset is. But the females, they tend to you know, express it out because they don't want to suffer more. It is a little biased. It may be the other way also. It depends on the experience, as I keep. So while speaking about the duration of, the duration of presentation of pain, as I had said earlier, the acute pain is of sudden onset, it is of definitive etiology and very short duration. It lasts for maximum 6 months. It is protective in nature and it lasts till the injured area heals. If untreated, there is always a possibility of progression to chronicity. Some of the examples like fracture and labor pain and minor scuffles or injuries, etc. This is what we call acute pain. Chronic pain. Chronic pain is something that lasts for more than 3 months. It is a constant, recurring, mild to moderate intensity. You see, the acute pain, the intensity is moderate to severe. Whereas chronic pain, it is mild to moderate intensity. It does not always have an identifiable cause. And the worst part is the great personal suffering the patient goes through because of pain. Some of the examples are neuropathic pain, the arthritic pain, cancer pain, and some of the atypical headaches that keep recurring. So, what are the signs and symptoms of pain? The symptoms are increased heart rate, all the sympathetic drives, whatever, heart rate increase, respiratory increase, elevated blood pressure, moaning and groaning happens, elevated blood sugar, the drive, that cortisol drive that happens to the pituitary axis. A lot of sweating will be there. Guarding of the area. For example, you take this pain of the appendicitis. If you try to palpate the abdomen, there will be complete guarding and there will be rigidity. So it is a protective reflex, okay, so that you don't unnecessarily get into the root cause and try to aggravate the pain. There will be dilated pupils, irritability. Whatever I have expressed on the left side is all acute pain. Whatever I have expressed on the right side probably is more of a chronic pain, like irritability, restlessness, depression, and loss of interest. Very quite common. Chronic pain is chronic suffering. So the patient tends to have fatigue, insomnia, anorexia, weight loss, hopelessness, anger. That is also very important. And they become helpless also. So what are the challenges when you want to look at how do you tackle pain? It is a very multifactorial and complexity of the pain is quite severe, and especially with related to cancer pain, it is mostly tumor and host related. Many of the pathophysiology of pain is very poorly understood, despite the advancement in the medical technology. The exact pathophysiology is not really known. And the worst part I tell you is, pain has been there for ages together. Even the treatments have been there for ages together. But from the past many few years, there is no new class of drugs that have ever been developed and say, yeah, this is the magic medicine that can cure off all the pain. That never happened, despite people constantly working and doing a lot of research. And when it comes to cancer pain, opioids still continues to be the therapeutic drug of choice, despite the progress. So when you evaluate a patient or when you assess a patient's pain history, this is the normal course of questionnaires we try to put across to the patient. What we call as PQRST approach. P is the provocative and what are the palliates the patient goes through, what causes pain, what makes the pain better, what makes the pain worse. Q is the quality. What does the pain feel like? Is it sharp? Is it dull? Is it stabbing? Is it burning or crushing? Region or radiation, like, where exactly is the pain located? Is it confined to one place? It is diffuse? Is it radiating to other places? Does it start elsewhere and now it has come and got localized to one part? Like, for example, the pain of the renal calculi, it starts at the left lower back, upper back, and if the stone moves from the kidney and it goes to the urinary bladder or in the en route in the ureter, the pain tends to get localized more and more, and the patient will have severe intense pain. So how severe is the pain? That's what is the severity, and time. When does the pain start? Is it present throughout the day and night? And are there any pain-free periods? And how does the pain behave when there is a movement? And how long does the pain last? So these are the PQRST approach for the pain. So once you know the basic concept of what is happening to the patient, you try to arrive at a diagnosis. You need to know the intensity of pain. So that is when the role of pain intensity scales come into picture. Okay, there are innumerable number of pain scales available, and most commonly followed, especially in the bedside, is what we call as a numerical pain rating scale, or NRS. Okay, and it is a very simple scale marked from 0 to 10. 0 is no pain, and 10 is the worst possible pain the patient has ever experienced. So you can actually categorize other types of variable pain and make it as mild, moderate, severe. And you can give it as 0 to 3 is mild, 3 to 6 is moderate, and anything more than 6 is considered as severe pain. Similarly, we have a visual analog scale from 0 to 100, and the patient identifies from the other side where the pain is, and based on the patient's identification, you will mark that pain as a visual analog scale, and others like Wong-Backer's scale in children, and sometimes we have pictorial scales for the children to identify. So these are simple pain intensity scale tools available, which you can constantly utilize, and you can arrive at a intensity with which the patient is suffering. So your judgment and assessment paves way for the type of medicine or medication you are going to give the patient. So after knowing all about these different types of pain, the origin, the type of duration, and the intensity, now what are the pain relieving methods you need to know? So we simply classify into pharmacological, non-pharmacological, neurological, and neurosurgical methods of tackling the pain. So the pharmacological pain management is the mainstay, or what we call as the cornerstone of the treatment for pain in pain patients. So we simply classify them into opioids, non-opioids, and adjuvants. Okay. So non-opioids are plenty. There are plenty of them in the market. Starting from a simple paracetamol, the higher dose of paracetamol, then you have what we call as the non-steroidal anti-inflammatory drugs. These are all non-opioids. And then we have the regular opioids. These are especially useful in cancer patients, not so much in non-cancer patients. And the most common opioids are mild and, the what we call as weak opioids and strong opioids. The weak ones are the codeines and the tramadols and what we call as tapentadol. These are other medicine. And the strong opioids are obviously the most common and most popular, morphine. And recently they have introduced to the market in India what we call as methadone. So these are the strong opioids. And you have something called adjuvants. Adjuvants are drugs that per se they themselves don't have the property of relieving the pain. But when you combine this with the opioid or a non-opioid, they actually potentiate the action of the non-opioids or the opioids and help in overcoming the pain, especially so if the pain is of neuropathic or a neuronal component. Okay? And others like local anesthetics and other things are also. So whenever we use this pain treatment, we go through some stepwise treatment for the pain, and this is especially so in the cancer setup. So the step one is the non-opioid, as I said, with or without adjuvant. Okay? Step two is a weak opioid, with or without a non-opioid, and with or without an adjuvant. Okay? For example, step one is probably a paracetamol with an adjuvant like a small dose of steroid, or something called as gabapentinoids, combination of gabapentin and pregabalin. These are some of the adjuvants. Step two is in adjuvant you can also include what we call as anti-epileptics and some anti-psychotic drugs also. Okay. Step two is a weak opioid like a tramadol with a paracetamol and a small dose of what we call as a steroid. So this is step two. Step two is a strong opioid like morphine and a non-opioid like a paracetamol and sometimes a gabapentin or a pregabalin. So this is how you give the medications based on the severity of the disease. So a mild, moderate and severe disease or a mild, moderate and severe pain presentation will make you decide which type of medicine to be given. It's a simple step ladder pattern of treating the analgesic medication. So some of the, especially in a cancer setup where I'm working, what really brings on the pain in these patients, you should always know. If it is a cancer tumor, like a liver tumor, it tends to stretch the liver and liver capsule and it brings the pain. Okay, and some of the bones that metastatized by the cancer, the bones tend to weaken and that causes pain. And if it is involving the spine, it tends to cause what we call as neuropathic pain. So this cancer tumor itself in various parts can bring the pain. Surgery, post-surgery, patient will have intense pain for many days, but this entire episode is reversible. So you can push this into an acute pain category and which goes away over a period of time because of the heat. Okay? Sometimes even the radiation therapy for the patient for the cancer may bring on pain, and it usually stays for some time and goes away on its own. Okay? It sometimes develops over a period of time, and it may also happen after many years. So this is also reported. And sometimes when you do therapeutic stem cell or bone marrow transplant, and especially if the transplant fails and if the patient develops something called as graft versus host disease, very common in stem cell or bone marrow transplant patients, or even in renal transplants, these people tend to develop pain. Chemotherapy may sometimes cause a lot of pain, intense reversible pain, but sometimes chemotherapy causes some very annoying type of side effect called as chemotherapy-induced peripheral neuropathy, which may or may not be reversible. So this also causes pain. Hormone therapy may cause muscle and bone pain, it's quite common. And other causes of pain may also be associated in cancer, like migraines, headaches, arthritis, chronic low back pains, fibromyalgic pains, very, very common. Okay. So how do you assess a patient? How do you assess the pain in such patients? So your very aim is to find the cause of the pain, whether it is reversible, that is why you'll have to find out, and you'll have to know what is the impact of pain on the patient and family, and then you'll have to sit and discuss on a board. You'll have to formulate a proper pain management, because this pain management, especially in a chronic ailment, is a very long drawn process. It's going to take a lot of time, and the patient and the family have to be actively involved. Repeated counseling is needed, and you have to support them both morally and physically. That is very, very important, and emotionally. So not only it's not just about formulating the pain treatment, but you will have to have a regular follow-up, because the follow-ups will give you a reassessment of the pain and its effects. It also gives a hint about the side effect of the medication you are giving, because this equally or sometimes I feel more important than what you are actually treating. And you will have to always think about non-pharmacological methods of relieving the pain. So sometimes, once you start treating and when they come back to you on an OPD basis, some responses will be like this, I still have pain, but it does not worry me anymore. So that is a very important, encouraging sign. It's still there, but it's not what you call pain. See, this is also very, very important. The most important thing is I can get on with my routine things every day, and the pain no longer bothers me. So these are some things which you should always think. So when I spoke about a holistic approach of tackling pain, this is what I meant. This is what we call as total pain management. So pain management is just not restricted to physical symptoms. You are just not concentrating on physical aspects. You are also seeing the social aspect of the patient, like family and financial worries. Loss of job and income, very, very important. And all of us are going through some critical situation because of the current existing problem. And this is always here. And loss of role play in the family as well as the workplace because of the limitation of the pain. So this is a social cause of the pain. And abandonment, abandoning the person or putting him in isolation. This is what some of the current situation is. And that itself brings on a lot of pain. Imagine somebody who is severely osteoarthritic and who is going through COVID issues, and if the person is isolated, not getting the medications properly, and this is what you call as social pain that you are not tackling. See, your patient is isolated, somebody who is vulnerable and getting isolated. The pain factors sometimes extrapolate itself and it causes severe agony. What about the psychological issues? If you don't tackle pain, the patient will develop anger. The patient may find the disfigurement happening, and fear of pain leading to death is very common. And obviously, they become very helpless. That is the psychological issue. What about spiritual aspect? Why it has happened to me? Why this particular cancer is causing so much agony for me? They show anger at God. They tell that I had all my faith in Him. I used to be spiritual every day, but still, this is what the God has given me. What is the end point? What it means nothing to me. Whatever effort I have put, it has gone for waste. And they also have this guilt factor that something has been done by me which has led to this particular situation. So this is what we call as total pain You will have to address all these issues and you will have to take the patient forward. Okay. What you should always remember when you're speaking of pain and the treatment is, especially with regards to cancer is always has an inflammatory component. Okay. So don't just think that cancer can always be tackled with only opioids and you have to just bombard the patient with a lot of medication. So always consider the inflammatory component of the cancer and also gives a small dose of non-steroidal anti-inflammatory drugs. That's why in that WHO ladder, if you just go back and see, plus or minus the other drugs are also included. Okay. Some of the adjuvants are also required, as I told you, especially the chemotherapy-induced neuropathic pain, chronic post-operative pain. There is something called post-herpetic neuralgic pain. I am sure most of you are familiar. Have anybody of you experienced this post-herpetic neuralgic patients in your clinic?
Yes, sir.
Yeah. You can actually see that the patient will always be in a very depressed mood. They feel very loss of interest will be there, and it is evident on their face the amount of pain they go through. Post-herpetic neuralgia is very
some patients come with hyperesthesia also.
Absolutely right. So that's quite true. And the other thing I wanted to bring to your notice is there's something called phantom limb pain. What is phantom limb pain? Anybody? Phantom limb.
The patient often feels pain in the limb which is amputated.
Very correct. So this is what we call as while during amputation, if the neuronal component of the nerve endings have been severely injured, and if you repeatedly traumatize the nerve and the vascular area around this nerve, that leads to phantom limb, and it usually comes on within few months and it lasts for a very long time. And the patient, I have seen some patients coming and telling me that had you not operated, it would have been better. The pain of this particular problem is more agonizing than what I had earlier. So, the patient would have presented with neurovascular complication of chronic smoking. We call it as thromboangiitis obliterans. This is something that is very painful, and the patient will have severe excruciating rest pain because of the completely impaired vascularity and the severely affected nerve endings. Okay, so they seek for operation. They come for operation, but when you do an amputation and you end up giving them phantom limb, I think that is the worst thing to happen. So you will have to take all the precautions. And that is why we call it as, in these days in the current pain clinics and pain management physicians, they foresee these might happen and they start the treatment well before the actual amputation happens. That's why we call it as preventive analgesia. This is what we call as preventive analgesia. Preventive is to take all the preventive measures to tackle the pain and reduce the intensity of the suffering after the procedure. That's why muscle spasms are quite common, and antidepressants and anti-epileptics are sometimes very carefully used to tackle the pain. Okay. So let's go to the pharmacological drugs quickly. Most of you are familiar. Paracetamol is a mild analgesic and an antipyretic, but you should remember when you use paracetamol at a higher dose, normally when you prescribe paracetamol, you write it as 500 milligram, and sometimes the most popular drug these days is 650 milligram. Dolo 650 you are all familiar with, but you should remember when you give paracetamol at a much higher dose like 1 gram or 2 grams, that acts like an analgesic. Okay, and the most important advantage of paracetamol is very uncommon side effect. Very rarely you can see somebody has suffered from paracetamol induced toxicity, unless patient also had some liver issues or something. It is very well tolerated by even GI sensitive. Literally no effect on the platelet function. This is very important. Platelets are very vital and prevent bleeding. Okay. Disadvantages, obviously, the frequency of administration. As I told you, potential for hepatotoxicity. Especially, you should be careful in old age, poor nutrition status, and fasting and anorexic patients, and even patients who are concurrently using alcohol abuse. So you have to be very careful. Usually, as I told you, it's about 500 milligram to 1 gram, sometimes up to 4 times. And it is also available as an intravenous drug. It was available as an 1 ampule drug, as an intramuscular also I have used it. A very common long-term complication of toxicity. And that you will have to keep a track and regularly do follow. So other drugs are the non-steroidal anti-inflammatory drugs. Why is it called non-steroidal? Because steroid itself is an anti-inflammatory drug. So any drugs that don't fit into the steroidal category is non-steroidal. So they are very potent analgesics and sometimes antipyretic also. Okay. So how do they act? If you just look at this nice diagram, whenever there is an injurious stimuli, can you see the arrow, all of you?
Yes, sir.
See, the injurious stimuli leads to cells extravasation of the cells happen, and that leads to formation of one important secretion called arachidonic acid. So this arachidonic acid has two enzymes. One is the lipoxygenase, which is not actively involved in inflammation, and the cyclooxygenase, or what we call as COX. Okay, so this cyclooxygenase further leads to the formation of prostaglandins, and prostaglandins have multiple actions on the body. Like they elevate the temperature and cause fever. They cause inflammation, and also they release local hormones which potentiate the pain. So cyclooxygenase leading to prostaglandins, and prostaglandin effects cause all these painful agony and fever. Okay, so these non-steroidal anti-inflammatory drugs, they inhibit this pathway. They actually prevent cyclooxygenase inhibition, prevents formation of prostaglandin, and that in turn reduces the inflammatory response and the pain. Okay, this is how the action happens. So what are the advantages of NSAIDs? They were very effective in control of inflammation and pain. They reduce the swelling. They instantly improve the mobility, flexibility, and range of motion. Simple example is somebody coming with severe shoulder pain, what we call as painful arc syndrome, because of the severe involvement of the acromial joint and the shoulder joint. They have severe limitation to lift their hand and form an arc over a period of time. So when they present to any OPD, the first drug you usually give is diclofenac. Okay, within 10 to 15 minutes, the range of movement will become very good. So they feel they will be very elated. But you should know how judiciously you should use these medications. Okay, and they also try to improve the quality of life and relatively low cost. That is, obviously, disadvantages. GI toxicity is the most common thing. Renal complications are very, very common because of the renal insufficiency and papillary necrosis, and it may also lead to hepatic dysfunction. Okay. So when you are selecting NSAIDs, you have to tailor the medicine according to the patient's present condition and requirement. Okay, always start with a very small effective dose and try to limit to as shortest interval as possible. Okay, and always try to prescribe a J protective drug like a ranitidine or an omeprazole, pantoprazole, or esomeprazole, whatever. So whenever you use NSAID, most commonly the drug that are employed is like ibuprofen, 400 milligram up to 1200 milligram in a day, and usually it carries less GA bleed risk, but it has very high GA toxicity, gastrointestinal reflexes and gastritis is very common. These are the other drugs which are commonly employed as NSAIDs. These are recently come in the market. Selective COX-2 inhibitor. As I told you in the previous pictorial diagram, where it inhibits the formation of prostaglandin. These selective COX-2 inhibitors, starting at 100 milligram, and diclofenac giving at around 50 to 100 milligram, and there is something called naproxen used at 250 milligrams. So these are simple examples of NSAIDs that we commonly employ in the market. And the other strong pain medications are the opioids, the cornerstone of cancer treatment. Weak opioids are something that should be always be started, and you should never replace a weak opioid with another weak opioid. Suppose, for example, you are giving, for example, you take tramadol, is a weak opioid. When somebody presents to you back within 3 days and they tell you that the pain is still severe and not able to tolerate, don't replace tramadol with another weak opioid like tapentadol. Go for a higher, stronger opioid. Okay. Always try to replace an inadequate weak opioid with a strong one is the message. Okay. So morphine is by far the most popular, most commonly used across the globe as a strong opioid for moderate to severe cancer pain. It is available as an oral medicine. It is available as an aqueous solution. It is available as a rectal suppository. So there are so many methods of giving morphine. Okay. It is available as an immediate release or a simple plain regular morphine, or it is available as a controlled release. Controlled release is it gets into the system, it acts like a reservoir, and it keeps releasing the drug whenever the blood levels keeps coming down. Okay. When you start a strong opioid like morphine, always monitor the side effects for the first few days. Not only monitor, you will have to bring it to the notice of the patient and the family. That is the most important. Okay. So what are the principles of treating the pain from opioids? Always give by the mouth, by the clock. So by the mouth, by the clock is you should stick to certain time frame and educate the patient that this is the exact time within which we have to take that. By the ladder. By the ladder means from the weaker opioid to the stronger opioid. You should go in a stepwise manner and individualize the dose titration. See, I might sometimes give one patient 10 milligram of morphine only 2 times daily, whereas another patient might have the same drug 6 times daily. So we'll have to individualize the titration as per the requirement. Always try to use adjuvants wherever there is possibility and give a lot of attention to small details of the patient. The more you spend time with the patient and the family and the patient's problem, the more you get the feedback and the better prepared you are to tackle the problem. Okay? So what about the opioid-induced side effects? These are very common side effects: the gastrointestinal, cutaneous, neurological, and autonomic. Gastrointestinal, the most common is constipation, nausea, vomiting. The nausea, vomiting usually goes off within 4 to 5 days, but the constipation stays for lifetime as long as the patient is taking morphine. Cutaneous complication is quite common. Patients usually come back to your OPD telling that they have severe itching and sometimes even sweating. And usually pruritus can be tackled with some mild antihistamines. Neurologic complications, sedation and fatigue. They may have headache at times. They may become delirious, especially elderly patients, confused. They may have clouded vision. Some patients have come back to be telling that sometimes have rubbing of my eyes in the morning. I can see a lot of bright light in the morning, and sometimes they feel very dizzy. They cannot walk independently to the toilet or to wherever it is. So you'll have to continuously monitor and support them. Some autonomic disturbance happen like xerostomia or even bladder dysfunction, especially urinary retention is quite common, and postural hypotension, very common. So always educate the patient to, get away from the bed in a very graded and staged manner, not in a very hurry, to prevent any hypotension. So some common concerns when you manage pain in your clinic is, one is sometimes the patients and family come and ask you, is it a very addicting drug, whatever they have given? It's a very valid concern, isn't it? Because they need to know what they're taking in, and you are accountable for it. Okay? So always carefully monitor the patient's progress, and you should always stop the drug whenever it is no longer required. Some ask for side effects, a very valid concern. Some of them will tell, sir, I can never tolerate this diclofenac. I had taken it once, and throughout the day, this pain was worse than what actual pain I had come to see you for. It's very, very common. You'll have to know what type of patient fits to what type of pain. Not all experience these side effects. Most of them will go through the treatment flawlessly without any problem. Okay, and the most important thing is patients, when they don't take the medications at a given time, they come back to you telling that they have pain which is never going. When you actually deep dive into their history and ask them whether they have taken the medicines properly or regularly, they always come back and tell you, no, I could not take. That is why when you prescribe any pain medications for a very long time, always ask your patient or the family to maintain what we call as a pain diary. They should write what time they took the medicine. If they have missed the medicine also, they should write. There should be a clear transparency between you and the patient for a better outcome for the patient. Okay, that is very important. So some of these other questions that are asked are, why is this medicine used for? How much of the medicine should I take? How long should I take? Will I get complete relief from the medicine? How long will I take? I'll get to know that the effect of the medicine is good. And only at certain times should I take, or certain times at night also should I take? So these are very common questions that are thrown at you, and you should be in a lot of patients to answer them back. Some of them can ask you, can I crush the medicine and make it a powder because I cannot swallow that medicine as a whole? And what are the side effects? They're very common. They come and ask you. You should be in a position to tackle each and every questions that are thrown at you. So for which you should know the proper, the literature of the medicine properly, the pharmacokinetics, dynamics, the effects of the side effects. Very, very. So some of them even question that what is the long-term effect of the medicine? How much will it cost me also? Okay, that is also important. Cost and finance are equally. So, one or two words about this nerve blocks, peripheral and central nerve blocks and sympathetic blocks. This itself is a very big chapter. I will sometime address this future classes. But what you should know about nerve blocks is what are the absolute contraindications. This you should know more than what the block is. Once you know the absolute contraindication, you will become comfortable how to tackle when the situation arises. So, patient refusal is probably the most common absolute contraindication, because if the patient says, I don't want this, don't be persistent, clearly take it in writing. The patient refusal is the cause for not giving the particular procedure. Okay, coagulopathies are very common. You'll have to properly evaluate the issue and then take it up for the procedure. Some of the patients are on anticoagulant drugs. Some of the patients have cardiac issues or neurological issues, and they will be on these drugs like aspirin, like clopidogrel and other medications. You'll have to be very careful. You know when to stop it before you give the block or the procedure, and when you restart. Okay. Infection at the site of injection is an absolute contraindication, because you are doing more harm to the patient than the use. Because once you give an injection at the infected site, the infection is bound to spread. So try to avoid giving it. So just to conclude, pain is a challenge even for the most experienced person. Careful history examination, drug profile, including side effects, are key to the management. One of the very important person in the New York Times had written, to the typical physician, my illness is a routine incident in his rounds, while for me it's the crisis of my life. I would feel better if I had a doctor who at least perceived this incongruity. I just wish he would give me his whole mind just once, be bonded with me for a brief space, survey my soul as well as my flesh to get at illness. For each man is ill in his own way. What wonderful words, isn't it? So you have to be more empathetic with your approach with the patient. William Osler has told, it is much more important to know what sort of patient has disease than what sort of disease patient has. These words are very, very important. You need to know the personality of the patient to tackle him than just yourself focused on the disease itself. If somebody walks in, you don't keep focusing on the disease and just don't tackle the disease. Treat the patient as well. Okay, so that ends my. Thank you.
Thank you so much, sir, for the
Any
beautiful
questions?
explanation of the pain management.
Yeah.
Now the session is open for the discussion.
Hello.
Hello.
Hello, sir.
Yeah, tell me, Naveen.
Sir, thank you, sir, for a good session. Sir, I want to know that in scorpion sting, they will use a cocktail one. So does it only acts as an antidote, or it also acts in the pain management, sir?
See, in this scorpion bite, what they do is they combine 2 to 3 medications. One to not only counter the irritation and the toxin effect of the scorpion, and the second one is it has to provide instant analgesia also at that site. Okay, and basically what happens is they act like a counter irritant and they try to reduce the pain, and also there will be some amount of edema that will happen around the bite. So they also ensure that the edema is also tackled. But many people say that scorpion bite doesn't have an effective antitoxin. So prevention is better than cure, no? Try avoid going to areas where these well. These are especially common in these rural areas and village suburbs. And how do you know? One method of knowing where the scorpion actually resides or not is, their burrows are actually flat and squarish. If a burrow is flat and squarish, that means a scorpion resides there. So you will have to effectively close it off. As you rightly said, cocktail is a mixture of multiple medications, one to counter the pain, counter the edema, counter the irritation, and to effectively diffuse the toxic effect of the scorpion. All said and done, this is the first aid. It is better to immediately after giving the first aid, better to shift to a place where all the facilities are available to, effectively and permanently tackle the problem. Most of the time, they require some amount of strong analgesia, reassurance, anxiolysis, and sometimes, they sweat and they perspire, they get very exhausted and tired. You may have to even supplement some IV fluids. Basic first aid management is what is required.
Okay, thank you, sir.
Yeah.
Sir, here we have a questions like, please say something about diabetic neuropathy.
Okay. Diabetic neuropathy itself is a very long and tedious section itself. Usually what happens, diabetic neuropathy is present after many years of the onset of the diabetes. Diabetic neuropathy is a result of constant presence of high glucose content in the vascular and the neuro components of the body, especially the peripheral, the vasculature and the neurons are the ones they get affected, and the most, what we call as difficult part of the diabetic neuropathy is mostly, unlike the other neuropathies, they never present early, and even if they present, they are mostly painless initially. Because it is painless initially, the patient tends to neglect this particular component, and the most important thing is diabetic neuropathy is self-hygiene plays a major role. Self-examination plays a very important role, and diabetic neuropathies over a long period of time tend to cause slow death of the nerves and vasculature of the affected part. And once they involve the deeper nerves, that is when they start presenting with severe pain. And once they present with pain, that is when you start giving the treatment. But sometimes they present as a small ulcer, it's a trophic ulcer, because many a time it is painless. So once they present as an ulcer, that is when you start evaluating the patient, and you'll get to know that the patient has diabetic neuropathy. For diabetic neuropathy, we usually start with small dose of mild analgesics, and we usually combine analgesic with some neuropathic analgesics like the gabapentins and the pregabalins, and sometimes mild antipsychotics and mild anxiolytics and even antiepileptics. Also, we use a lot of complementary alternative medications, the local medications and local therapies. And having said and done, see, the single most important factor for diabetic neuropathy is the continuous high glucose levels. So anybody who has neglected himself or herself and not been properly evaluated, they are bound to suffer from diabetic neuropathy. It's extremely common. It happens after about 10 to 15 years of onset of diabetes, and this is about it. Many of them end up in staged multiple amputations. Very, very common. They just go through multiple stages of amputations. Very annoying, very disturbing, and you can actually put me some thought process of how do you manage this diabetic neuropathy from Ayurvedic point of view. I hope there is enough time for discussing on this, otherwise we'll take it up as a separate chapter sometime.